Okay, folks, we are going to talk about some cardiomyopathies. Still under the concept of perfusion. This is in chapter 28, pages 802 to 809 in your Med-Surg book. The definition according to your Med-Surg book says that cardiomyopathies is a disease process of the heart muscle that causes cardiac dysfunction resulting in heart failure, dysrhythmias, and sudden death in certain cardiomyopathies. Cardiomyopathies are classified according to the structural and functional abnormalities of the heart muscle. There are three types that we're going to talk about, and those types are dilated cardiomyopathy, hypertrophic cardiomyopathy, and restrictive cardiomyopathy. So remember, the structure and functional abnormalities of the heart muscles is what makes it a cardiomyopathy. So when we talk about systole, you've talked about systole quite a bit in the last unit, and we'll talk about systole some more. So systole and diastole. What happens during systole? The thought should come to your mind is when the heart contracts, when the heart's at work. It is the period of time of contraction of the ventricles of the heart that occurs between the first and second heart sound. Systole causes the ejection of blood into the aorta or the pulmonary trunk. So we're going out of the heart to the body, or we're leaving the right ventricle going to the lungs to pick up some oxygen. So when we have systolic dysfunction, it's characterized by a decrease in myocardial contractility, a decrease in global myocardial contractility, which is the left ventricle, and that all equals a reduction of left ventricular end diastolic function. I left these up here, and yes, I'm going to read from the slide on a few because these are a lot of things that you need to know, learn, and some of these words are very tricky and they're come from notes passed along. So I am doing you a favor of leaving you some notes on the PowerPoint slide. So on to diastole. What is diastole? What happens during diastole? Well, the thought that comes to mind should be when the heart is at rest. So during diastole, it's the period of relaxation of the heart muscle. It's accompanied by filling up the chambers, the ventricles, with blood. They're fixing to work to go into systole and pump. So a diastolic dysfunction refers to cardiac dysfunction with abnormal left ventricular relaxation and filling. So there's an abnormality happening with that filling in the left ventricle. Diastolic dysfunction is accompanied by elevated filling pressures. And a little bit, we'll talk about how we figure all that out. So this slide represents systolic versus diastolic dysfunction. Those definitions are there and left for a purpose. So when we talk about cardiomyopathies, I'm going to mention the word pathophysiology of all cardiomyopathies is a serious event that accumulates impaired cardiac output. So something's going on in the ventricles, the heart muscle wall itself, and also there's an accumulation that inhibits impaired cardiac output. Ms. Doigas are going to talk about all these hemodynamics and all of these things that you will need to know. So with this pathophysiology of cardiomyopathy, there's a decreased stroke volume. There is an initiation of the renin-angiotensin-aldosterone response, which causes a result of increased sodium and fluid retention. Hence, we're going to learn as nurses to talk to our clients about sodium and fluid retention. And all of this disarray and dysfunction results in an increased workload on the heart. So if I'm increasing my workload on the heart, I need more oxygen, I need more pump, but I don't have it. And alterations in these cardiomyopathies, as I said earlier, can lead to heart failure. Remember that sodium is the major electrolyte involved in cardiomyopathies. So when we talk about dilated cardiomyopathy, it's also known as congestive. Think of the word congested. Systolic function is related to the abnormal dilation of the heart chamber. So in dilated cardiomyopathy, this is the most common form of a cardiomyopathy, and the ventricles dilate and they can't function, they can't pump. The ventricles have an elevated systolic and diastolic volume, but a decreased ejection fraction. There's reason behind that. Hypertrophic cardiomyopathy, you have a diastolic dysfunction related to abnormal hypertrophy in the intraventricular septal wall and the ventricles. It's like going to the gym, as somebody said in the last, I heard it, we were talking about working that heart so hard, it's building muscle, well, it overbuilds. Restrictive cardiomyopathy is just as the restrictive means. In diastole, dysfunction related to the non-compliant stiff ventricles. So that heart cannot, Starling law, squeeze as tight as it needs to anymore. So let's look at this picture. In the left side of the picture, we see a normal heart. Ventricles look nice. You see the walls of the ventricle, see the walls of the atrium, see the aorta. And in this picture, we're talking about dilated cardiomyopathy. And when we talk about dilated cardiomyopathy, there's a disease of the heart associated with dysfunction during systole. The causes of this and all the other things that go along we'll get to in the next slide, but genetics, non-genetics, and acquired disease process. So here, again, if you will look, these ventricles in this cross section of a piece of the heart, human heart, in the gross anatomy labs, you'll see that they're very dilated. So we're going to talk about causes, pathophysiology, why it happens, etiology, symptoms, diagnostics, treatment, and nursing care. Now again, dilated cardiomyopathy is also known as congestive cardiomyopathy. Remember that it is, and it happens during systole. The etiology of this type cardiomyopathy is idiopathic. It can be genetic, family history of, first-line relatives, toxins such as chemotherapy, alcohol abuse, excessive alcohol abuse, viral infections, HIV, and sometimes pregnancy. In the pathophysiological part of it, I'm just going to touch lightly. It is a diffuse necrosis of myocardial cells, and it decreases actin and myosin inside the muscles themselves, causing the dilatation of the ventricles, and sometimes without, causing that muscle wall to grow larger. Remember, systolic dysfunction, the ventricles have more volume, but its ejection fraction is decreased. The valves in these ventricles, think of in the left ventricle, pumping out the aortic valve to the rest of the body. The valves can weaken secondary to the dilatation from the ventricle. And then we also get into trouble with atrial and ventricular thrombi can form around these valves, and we know what that can cause. So severe congestive heart failure, severe weakness, tachybrady-arrhythmias, PEs, DVTs, syncopal episodes. Infants and children, when they have upper respiratory tract infections and even pneumonia, this can happen to them as well, dilated cardiomyopathies. And these children have poor weight gain, poor feeding, they can't breathe and suck, increased sweating when they're trying to eat, they're pale, they're short of breath, and they wheeze a lot. And you'll hear what's called a diastolic murmur with these. So how do we know we have a dilated cardiomyopathy? One of the first things that you'll see done for these folks and diagnostics is an echocardiogram. It can be either a regular ultrasound echo or a TEE. And what they're looking for is the wall size of the ventricles, and they will be dilated. Sometimes just on a chest x-ray alone, the cardiac size can show cardiomegaly. And then they'll end up doing a cardiac cath to measure the pressures inside the heart. And sometimes on EKGs, you'll see some dysrhythmias because the heart is having trouble pumping all that blood. Sometimes you will see, and when they do the cardiac cath, they'll do an endomyocardial biopsy to see if there is an infection causing a dilated cardiomyopathy. How are we going to treat these folks? We're going to identify the cause and treat appropriately. We're going to manage the heart failure and the arrhythmias. Some folks may need ICD pacemakers and other assisted devices, and some even so bad when their ejection fraction is less than 20%, they can be put on a heart transplant list. There is no cure for dilated cardiomyopathy. Once we stretch that muscle out, it does not go back to the way it was before. Because of arrhythmias, these folks need to be on anticoagulants. They will need diuretics to help get rid of fluid, inotropes to make that heart squeeze harder, beta blockers to slow the workload time down and keep that blood pressure down. You'll also see that folks that can't tolerate beta blockers will also can be put on ACE inhibitors. So when we talk about nursing care for dilated cardiomyopathies, what do you think you might see with these folks? Their heart's floppy, it's not able to function. So what do you think you might see? So you might see somebody that has trouble breathing because they're full of fluid. So we have to assess their heart tones, and we have to listen for murmurs. When you listen to that lub-dub sound, you will hear something extra in there. If you're not sure what you hear, then you get somebody else, and they can help you identify the extra heart sounds. Murmurs you will hear. Murmurs are swishes inside the heart tone sound areas. You're going to assess lungs. If they're dilated cardiomyopathy and they got extra fluid on board, we need to know if they're fluid volume overloaded. So you're going to hear some crackles. These folks are going to have some pulmonary edema. Think about where this blood is going. You'll see JVD on them. You will check their vital signs, check their blood pressure specifically. Heart rate tells you how hard the heart is working. Blood pressure tells you what systole and diastole is doing. You need an EKG. You need to record daily weights on these folks. And the reason being is when their weight changes, you know, it's time for diuretics. It's time to get rid of some fluid. Accurate eyes and nose, what goes in must come out, but we need to keep accurate eyes and nose. So if this patient was in critical care, you would be doing, if stable, vital signs hourly. If not stable, more frequently. You would be doing accurate eyes and nose, Q 1 hour, daily weights, first thing in the morning. You would be assessing their lung sounds at least every 2 hours. And you have to keep an eye on these folks because they can go into flash pulmonary edema very quickly. What does nursing need to do as far as education with these dilated cardiomyopathy folks? Now, we just talked about nursing care and things that you need to assess. So what are we going to educate? Med compliance is very important. Some people just don't like to take their medicine. They don't like the way it makes them feel. But with these folks, they need those medications. You need to talk to them about the disease process. Talk to them about weighing daily. Talk about fluid restriction. You need to limit their fluids and make sure that their output is equivalent. And then also is recommended by the American Heart Association and the American College of Cardiology that if these folks have issues and children with issues, they need to have genetic testing for first-degree relatives. So remember, this is also known as congestive cardiomyopathy, dilated cardiomyopathy, that floppy heart, and they got extra fluid. It is a systole dysfunction. Hypertrophic cardiomyopathy. Well, let's look at this interseptal wall here, intraventricular septal wall, if you will. Look and note how thickened the ventricular septum is. And hypertrophic means that we're increasing in size. So we see a smaller ventricle with hypertrophic cardiomyopathy. On the left side, we see a normal heart. So just remember the way the heart looks and the size of that ventricle. So in hypertrophic cardiomyopathy, it is a diastolic dysfunction because that inner portion of that septal wall has thickened and it prevents that left ventricular from pumping the way that it needs to pump. So here's a picture, Gross Anatomy Lab. I don't know if Baptist still has theirs, but it was a very fascinating area to go to whenever I was in nursing school. So again, causes, pathosymptoms, diagnostic treatments, and nursing care, all listed right there. These are the things that you need to familiarize yourself with. Causes hypertrophic cardiomyopathy. It's rare, it's inherited, and it can be idiopathic, caused from disease processes. Hypertrophy of the ventricles is the left and the right ventricle, most common. So what it does is it causes the asymmetry of the arteries. It doesn't allow the heart to pump the way that it needs to pump. Now you would think because this heart wall is thicker, it would pump better, but no, it's too thick to pump. So the heart essentially becomes hard and stiff and thick and hard to relax because the mitral or the tricuspid valves also have a tendency to leak. Diastolic dysfunction, we said that. Dependent on atrial kick for what? First thought that comes to your head should be cardiac output. So our heart depends on that atrial kick for cardiac output. So what do you think you're going to see in these folks? Symptoms: dyspnea. I can't breathe because my heart's not pumping. It doesn't have enough strength to pump. Angina, chest pain, heart's too big to work. Fatigue, I'm tired, heart's too big to work. Syncopal episodes because I'm not getting the blood that I need to my brain. That left ventricle is going to pump out the aorta, and the branches off the aorta, one, carotid arteries, that's going to go to your brain and prevent you from working the way that you need to work. Fatigue and syncope, palpitations. I'm trying really hard to work, but my muscle is just not doing it. Heart failure, dysrhythmias. So the biggest dysrhythmias for hypertrophic cardiomyopathy is ventricular tachycardia and ventricular fibrillation. Ms. Kofke taught you a lot about those, so you need to know what they are. You'll hear murmurs again. These folks have an exercise intolerance, so it's not a conducive idea to put them on the treadmill to see what their tolerance is to exercise. These folks have a tendency for dysrhythmias, just said, ventricular tach, VFib, So you sure as heck don't want them to be on the treadmill when that happens. You're going to see some edema in extremities, and these folks are the ones that will collapse playing sports, sudden death. Infants, when they have inherited or idiopathic, genetically given, these folks, babies, are short of breath. The heart can't work. They're trying to eat. They can't do it. They have poor growth, excessive sweating when they're trying to eat. Their activity is nil to none. They cry and they're very agitated when they try to eat. Can't do it. How are we going to diagnose hypertrophic cardiomyopathy? We're going to do an echo. We're going to look and see what the heart wall looks like, in particular the intraventricular septal wall. If I could point at this picture, it's sticking right there at you, is that inner wall. So we're going to evaluate the size of the heart. We're going to look at what the ejection fraction is of the ventricles. We're also going to look at the valves. We're going to do an EKG to look at any cardiac stress or workload on the heart, any dysrhythmias we might see on the EKG. And some of these folks might need to wear a Holter monitor 24 to 48 hours because what is going on right now may not be going on later. So Holter monitors are good for that reason. How are we going to treat them? Symptomatic treatment, calcium channel blockers or beta blockers. We're going to identify the cause of their hypertrophic cardiomyopathy, septal wall ablation to remove a thickened wall so that we can reduce the volume. ICDs and pacemakers for folks that have dysrhythmias. And these folks are also heart transplant as well. If they have hypertrophic cardiomyopathies, echoes need to be done yearly to see the size of the intraventricular septal wall to make sure that it's not getting larger and we're not getting into trouble, especially in the teen years. So if there is no growth in the ventricular walls, then they can go every 5 years after that. There is no cure for this hypertrophic cardiomyopathy either. So again, no competitive sports. This is what causes sudden cardiac death in folks who play competitive sports. Nursing care for these hypertrophic cardiomyopathy folks. Assess that heart. You hear something different than the lub dub, lub dub, lub dub. You're going to get somebody and say, hey, will you listen to this with me? You're going to listen to their heart and lung sounds. We're going to do those EKGs, nursing is. We're going to educate. Oh, Melinda. We're going to educate to avoid dehydration. If these folks get dehydrated, their preload and their cardiac output will be messed up. They can exercise, but not strenuously, but they need to limit those strenuous activities. No nitrates or morphine. What happens when you give a nitrate to a patient? What are we decreasing in their body? Preload, thus decreasing our cardiac output. So, restrictive cardiomyopathy, let's look at this one. So on the left side, you have a normal heart. When we look at the normal heart, we see that the heart walls are uniformly, symmetrically. We see that we don't have any overgrowth. Our valves are looking good, and our chambers look just as good. So let's look at this restrictive cardiomyopathy on the right side. We see an enlarged atrium on that heart's left side, and we see a rigid ventricular wall on that left side. If I'm rigid, I can't squeeze and pump the blood out of my body that I need to, or out of my heart, I should say. So here's a beautiful picture. I love pictures. So again, we're going to do the causes, a little bit of patho, some symptoms, some diagnostics, treatments, and nursing care on restrictive cardiomyopathy. Their heart is so restrictive, it cannot pump. You can see by this picture, it is so, and this is a bad case. There is nothing there chamber-wise, very little, very little. So again, the etiology, what causes this is idiopathic or inherited. So pathophysiologically, we have a rigid ventricle walls that impair diastole feeling. There's nowhere for it to feel. It's so squeezed, so tight. And the ventricles can't stretch for the blood to fill up. The blood backs up in the atria and the lungs. And what does that do? When blood backs up into the atria and the lungs, well, where's it coming from? If it's coming into the right atrium, then it's coming from the rest of the body. If it's going into the left atrium, it's coming back from the lungs. Well, if my left ventricle is so restricted, I can't pump good oxygenated blood out to the rest of my body. So signs and symptoms. What do you think you might see in these folks with a restrictive cardiomyopathy? I might see somebody with dyspnea, heart failure, chest pain, non-productive cough because I'm full of fluid because I can't get it to go anywhere, systolic murmurs, syncopal episodes because I can't squeeze that ventricle because it's so restricted I can't get it out the rest of my body to go to my brain. And these folks also have an exercise intolerance. Children with restrictive cardiomyopathies, you will see that children who have repetitive lung infections or asthma have restriction. You'll also see those restrictions in their lungs. So how are we going to diagnose restrictive cardiomyopathy? We're going to diagnose with a chest x-ray. Incidentally, we're going to see that the heart is enlarged. These folks have heart failure. EKGs, we can see any dysrhythmias or any issues on the EKG. We need to know what their rhythm is on all of these cardiomyopathies. We're going to do an echocardiogram, see how thick those walls are. And we're also going to do a cardiac cath to measure the pressures inside the heart. The only thing that I really and truthfully, honestly see is this little bitty white area up here to the left side of the screen. And I don't see any place else for any blood to fill up. We're going to treat these folks, tell them that they can't do any competitive sports whatsoever. These folks need to be on the heart transplant list. So all three different types of cardiomyopathies need to be on the heart transplant list, and eventually we'll end up there. Meds, we're going to help them out with diuretics to get rid of the fluid because the heart can't pump the fluid around. We put them on some beta blockers, decrease that workload of the heart. And they're going to need anticoagulants because blood has a tendency to pool. Nursing care, we are going to teach them about taking their beta blockers, and we're going to teach them that it's not a good idea to discontinue their beta blockers because they're going to get in trouble. We're going to check their vital signs, heart rate, blood pressure, all of that. O2 sats, we're going to check their I's and O's. We're going to teach them about a cardiac prudent diet. What is a cardiac prudent diet? I'm sure you remember low sodium, low fat. We're going to look for edema. And these folks, you will see, will need some help getting this fluid back up from the lower extremities to the mid-core. And then again, limit activity, intolerant to activity. So these folks sometimes will need what's called an IntraAortic balloon pump. We're going to put them on this balloon pump, and we're going to help provide them with some assistance for their compromised heart. That's the purpose of an IntraAortic balloon pump. There's a video that you can watch that tells you all about it. The indication is for a post-CABG patient that has some cardiomyopathy, acute MI patients that are having cardiomyopathy issues and complications, left ventricular failure patients, cardiogenic shock, and the bridge to transplant. So these cardiomyopathy folks that are in the bridge to get their heart may need an intra-aortic balloon pump. They're going to need to be in CVICU or critical care and monitored very frequently. This intra-aortic balloon pump is an inflatable balloon that's on the end of a catheter, and this catheter is done like a cardiac cath procedure through a sheath, through the femoral artery, threaded up to the descending thoracic aorta, and this balloon is going to inflate during diastole to help perfuse the coronary arteries and the periphery arteries. But it will deflate just before systole, decreasing the pressure of the left ventricle. So we're going to help that left ventricle out. We're going to help the heart out altogether. So the left ventricle either is dilated, restricted, or enlarged, and it needs assistance in overcoming the ability to eject blood out of the left ventricle. So with the balloon pump, we're going to decrease that left ventricular afterload. Clients will have to be hemodynamically monitored while the balloon pump is in place. You will see that with the balloon pump, you will be able to monitor arterial pressures. And this is a short-term event until we can either get them to something else or get them a heart. So the effects of the intra-aortic balloon pump is going to augment the aortic pressure and forward push flow, increasing the coronary perfusion. Not only does that heart gonna pump blood to the rest of the body or to the lungs to pick up oxygen, but the coronary perfusion is important as well. The heart needs blood to function. The effects of the intra-aortic balloon pump is going to decrease the preload and the afterload, increasing systemic stroke volume and cardiac output. Videos to come. Here they are. So balloon catheters placed in the descending thoracic arch. The balloon inflation begins with the aortic valves closed. Time of early diastole. The dichrotic notch you will see in the videos just looks like the arterial lines that you'll see in the Mitchell Community College critical care as we run the A lines. So very important for you to watch. They will help you, I promise, understand what this intra-aortic balloon pump looks like and how it functions. So here's some pictures. So here's this catheter on the left in diastole with the balloon inflating. And then here in systole, the balloon is going to deflate. It's kind of like a suction. So we're going to be helping this left ventricular area, and we're going to be able to pull the blood out and help it get pushed out the left ventricle, decreasing the workload so that it can get it out of the left ventricle to the rest of the body. So here we talked about these areas of arteries in the AAA and TA. So this one being in the aorta and the aortic close to the arch. And here you will see the pictures as the balloon pump works. Watch those videos. I'm telling you, they're going to help you understand how the balloon pump works. It's kind of hard to explain it because I have to be at it, the balloon pump, to explain it to you, to show you how all of its functions do. So watch the videos. The purpose, providing long-term support for a decompensated heart, assist or replace the action of the ventricle, and then these ventricular assist devices is what we're talking about now, sorry. The purpose of a ventricular assist device is to provide long-term support for a decompensated heart. You may have seen somebody come into the emergency room or pick somebody up, or you may see when you have your cardiac cath lab rotation, these ventricular assisted devices. As the purpose states, may be implanted or they may be external. Indications are for ventricular failure associated with a heart attack. and they're waiting for a donor or an artificial heart. They're used for bridge of recovery, bridge to transplant, and there are several different types. You do not need to know the different types, but you just need to know what the purpose is and what they're indicated for. Ventricular assist devices, just what they say. They're assisting that ventricle to work. Here's a picture of a gentleman. His is on the outside. Left ventricular device, LVAD, you'll hear them called, connected to the heart. It has its little battery box, and this patient will learn what their battery life is, something nursing can help them remember. And then the LVAD pumps blood into the aorta so that it can get out to the rest of the body. Left ventricular assisted device, LVAD. Heart transplant. How are we going to take care of heart transplant patients? Not everyone gets a heart. Gotta sneeze. And there are many people on the list to get a heart, but not everyone gets a heart. It is very fortunate for those that are able to get a heart. Wonderful stories out there. So transplanted from a donor with a comparable weight and ABO compatibility from the recipient to the donor. They have to be donated or transplanted within a 4 to 6 hour window after procurement, after the patient dies, and then the heart is taken from the person who is donating to the donor. And there's lots of things this patient has to go through preoperatively before they're even considered to be put on the heart transplant. So remember that for nursing. The donor, free of infection, free of malignancies, free of chest trauma, and they have to be declared brain dead. They have to be considered a cadaver and an organ donor. Clients with history of noncompliance, depression, or ineffective coping skills, stress management, are not considered good candidates. If they're not going to take care of their body prior to, more than likely they're not going to take care of their body afterwards. So you're going to see the first line recipients: ischemic heart disease, cardiomyopathies that we just went over, severe valvular disease, we will go over, and end-stage heart failure. Just recently, a very dear friend of mine, her husband passed away. He was on the heart transplant list. He did not get his heart. And it is so sad to watch them go through all that they go through, the hope and desire to need a heart and not be able to get one. Very sad when they don't, but it's a very successful story when they are able to get their heart transplant. The procedures performed on patients, like I said, that are end stage heart failure, and then your ischemic heart disease, ischemic heart disease, cardiomyopathies, and severe valve disease. So recipient's own heart is orthotopic, is a recipient's own heart is either removed or, less commonly, just scratch what I just said. Survival rate of heart transplants have been researched and shown up to the average of 15 years postoperatively. Recipient is prepared for open heart surgery. A mediastinal sternotomy is performed. Placed on cardiopulmonary bypass. That's an interesting video if you want to look it up on YouTube. Anterior portions of the recipient's heart are removed and replaced with the donor heart. Postop care is similar to that of a post-CABG. So they're going to be in critical care, CVICU, and the big facilities where they do these. They were going to protect these folks from infection because they're going to be immunocompromised. Positive pressure isolation and protective isolation for a while after the procedure, and then as long as they're lifelong immunosuppressed. And they're going to be both immunosuppressed and on steroids. So you'll see them being on Cymedrol, Cellset, Prograft, Imuran, and Senda Immune. So Anna has some good stories about some of these medications with her young son, Willie, and I'm sure she'll share them with you. So then we need to watch these patients and teach these patients to watch for rejection. What signs and symptoms of rejection? Ms. McHargue has left you notes: increased temp, rigors, shakes, chills, hard chills, malaise, tired and fatigued, and dysrhythmias. We're going to monitor by doing endocardial biopsies. Anytime they transplant an organ, they're going to do some sort of biopsies to make sure that the body is not rejecting it and the organ that you just had implanted is still functioning. Complications that can happen with these heart transplant folks is they could get hypertensive from the medications. Cholesterol can increase because they're on steroids. They can gain weight, they can retain fluid, and they can even have malignancies because they're immunocompromised. These folks you have to think about when heart transplants happen is they cost lots of money. I do not have a clue at this day and age the price that is on a heart transplant, but what a precious gift to get. The prognosis you have to think about of the patient that's going to be the recipient, lifelong meds, monitoring. Just like I said earlier, when we do these, we have to do biopsies, so they have to have labs and all kinds of procedures. Sometimes they have to have cardiac caths just to see what the heart looks like and the pressures inside the heart. So here is a video. I don't put these up here just to put them up here. I put them here so you can watch them and learn from how things look and how things work. So nursing assessment for cardiomyopathies. We're going to jump off the train of heart transplant. So what are you going to do when you have a client that comes in a facility or a client that comes into the doctor's office and they've got cardiomyopathy? Depending on what kind of cardiomyopathy, you may determine or discover some different things, but a thorough assessment on these folks. H&P is going to focus on signs and symptoms of heart failure. I would remember those signs and symptoms of heart failure. So depending if it's right or left, depending on what my lungs sound like, I could have all kinds of sounds, heart and lung. So the detailed H&P, we need to start somewhere. So the baseline before sickness, early stages of cardiomyopathies is going to lead you to see further down the road how detailed that H&P is going to give you information of the progression of their cardiomyopathy. We're going to identify any etiological, what caused their cardiomyopathy? How did it happen? So we assess cardiac-wise, and when we assess cardiac-wise, we need to assess their rhythm, their vital signs. All vital signs are very important. We need to look to see if they have JVD, edema, assess their pulses. Are they symmetrical? What are they bounding 2, 3, 4 plus? Heart tones, you may hear extras, S1, S2s, some murmurs and things like that. But going back to that etiological factor, back up there for just a second. So when you take the history on these patients that come into you that you may see, smoking, heavy alcohol intake, recent illness or pregnancy, history of disease with immediate family members, so genetics as well. So back to our assessing, we'll go back to pulmonary, listen to their lungs. You hear crackles in the bases, you need to let somebody know. Are they on medication to take care of those crackles in the bases? What kind of medication are they taking? What do we need to teach them about that medication? What labs do we need to look at? all the important things that nursing needs to do. And you know what to do because we've been working on it. So listening to breath sounds, checking their oxygen saturations. Crackles, we hear them, we need to find out medications that they're taking. Are they short of breath? Do they have trouble breathing when they lay down? Do they wake up in the middle of the night gasping for air? Paroxysmal nocturnal dyspnea. Paroxysmal nocturnal dyspnea is that sudden wake up, just like I said, in the middle of the night gasping for air. Neurologically, are they having syncopal episodes because my heart's not strong enough to pump the blood out my aortic arch through the branches and go up to my carotid arteries to supply my brain? Am I having dizzy spells? Now, the GIGU is, what kind of diet are they on? What do they need to monitor? My pause is for you to say, Ms. McHargue said sodium, so I need to look at their sodium level. Are they monitoring their sodium level, and do they have edema in their lower extremities? What is their weight like? Have they gained a large amount of weight in the last week? And we need to monitor their intake and their output. We said something about earlier, their intake, monitoring how much they put in, because we don't want them to get into trouble. And we need to know, GU-wise, are they putting out what they at least equal taking in? Psychosocial, interesting. What is cardiomyopathy that they have impacting their life? Does it change their ADLs? Are they able to take care of themselves? Can they walk to the bathroom to go to the bathroom? Can they walk to the kitchen to cook for themselves? Can they lay down in the bed at night? Are they able to perform their ADLs? These are questions that we need to ask them. Do they have stress? Everybody has stress. Some stress is good, some is not so good. But if a certain amount of stress or bad stress can cause our heart not to function the way that it needs to function. Is the client having anxiety or depression? If your client has anxiety, what is their anxiety coming from? Is it from all the stress they're having? Is it because they can't afford their medicine? Is what reason? And depression leads to people not being compliant. Do they have support? Support groups, support from family, support from friends, support from loved ones? And here's something I found very interesting from the American Heart Association and American College of Cardiology uses this to determine the progression of the disease. How many pillows is this person sleeping on at night? Did we start with one pillow, now we're up to 3 or 4? Are we sitting in the recliner to sleep? Are they having more weight gain and trouble getting rid of fluid and limitation of ADLs? So pillows, weight, and limitation of ADLs is what American Heart Association and the American College of Cardiology is going to determine the progression of the diseases with cardiomyopathies. Nursing diagnoses. Oh boy, priority problems. Perfusion is what we're talking about. The heart can't perfuse. So we're going to see these folks have decreased cardio outputs, risk for ineffective cardiac, cerebral, peripheral, and or renal perfusion, impaired gas exchange, activity intolerance, anxiety, powerlessness because I have no control over what is happening to me, non-adherence to medications. So collaborative problems that I may see in these folks are potential complications: heart failure, ventricular dysrhythmias, atrial dysrhythmias, cardiac conduction defects, pulmonary or cerebral embolism, and valvular dysfunction. We need a cardiologist on board, and we probably need some sort of pulmonology and some sort of renal as well. Dietitian, nurses, and other folks. Social worker, you can name them. So planning and making goals for these folks with cardiomyopathies as the major goal for this patients include improvement or maintaining cardiac output, increased activity intolerance, slowly, no heavy competitive sports, reducing that anxiety, adherence to self-care, and absence of complications. Now, Ms. McHargue, what do I need to know is the priority for this patient? It's perfusion. The problem is perfusion. The priority is to improve or maintain that cardiac output. It's top on the list for a reason. Nursing interventions, yes, I left this blank. Page 808 in your textbook. It will tell you interventions. You can think of interventions for these clients that you're going to see problems of all sorts and kinds. And here are some other videos. Heart transplant, Impella is the intra-aortic balloon pump. I've seen it used. I've used it with patients, taking care of patients with them in. LVADs, not so much. So here's a video. Any video that is listed, it will help you understand. I cannot express that enough. It will help you understand what's going on with these folks. So I'm going to stop the share. Replay the video. Again, I'm saying to you, if you have questions about what I just taught you, please reach out to me and I will help you as best I can understand about cardiomyopathies. Have a great evening and we'll see you soon.